Welcome everybody, and we're excited today. Shreesha Danareddy is going to give us a brief update on some crisp anti-retroviral drug interactions, and I think she's got an excellent outline of some of the key drug interactions. She's an assistant professor here at the University of Washington, an excellent teacher and clinician, and I'll turn it over to Shreesha.
Thanks, David. So I was telling David I feel a little intimidated because there's a pharmacist in the PharmD in the audience, so hopefully not too much heckling. But obviously there's many drug interactions, and I'm not going to pretend to even go through even the most important ones, but I picked out 10. So a top 10 list that I thought people should know or may not know some of these interactions. And for a more comprehensive review, you can go to two different websites here, HIVdruginteractions.org, and then our clinic website actually has a really nice review of the key drug interactions with major classes and the antiretrovirals. So, number one, Addas and acid suppressors. So most people are aware of this, but actually there was a paper that came out a couple of years ago about the number one drug interaction with ARVs in inpatient. And it was with acid suppressors and Addas. And as most of us know, Addas requires an acidic environment in the stomach to be absorbed appropriately and optimally, and acid suppression with either H2 blockers or PPIs can limit that absorption and potentially lead to suboptimal drug levels. So here is some of the information from the package insert, actually. For the typical dosing that we use for Addas is 300 milligrams boosted with ritonavir 100 milligrams. And if you're going to do that, you want to make sure that you dose your H2 blocker or PPI about 12 hours apart. The H2 blocker greater than 10 hours after. But what we typically tell patients is whenever you're taking your Addas, make sure that you take your acid suppression 12 hours apart. It used to be that we couldn't really do PPIs, or we were told not to do PPIs with Addas, but in a couple of years ago, the package insert did change to reflect that you can use PPIs if they're dosed 12 hours apart, and not exceeding usually the equivalent of about 20 milligrams of omeprazole per day. For, and again, not exceeding 300 milligrams of ranitidine. Usually we do once daily dosing of ranitidine just to make sure that we're not really interfering with the Addas absorption. In terms of unboosted Addas, not a lot of people give unboosted Addas. We typically don't in our clinic, but if there is a reason you're doing that, we want to make sure, again, that we don't give the H2 blocker with the Addas at least 10 hours after or 2 hours before. Essentially, give the Addas 2 hours before. And then do not exceed 150 milligrams of ranitidine or equivalent. And then with unboosting, you want to avoid the PPIs altogether, just because you're decreasing the potential levels of Addas even further. And then for treatment-experienced patients, and I don't know how many people actually do this, because the package insert recommends Addas 400 milligrams with ritonavir 100 milligrams for treatment-experienced patients, so not naive patients who are on tenofovir and an H2 blocker. And we typically don't recommend PPIs in patients who are treatment-experienced on Addas. All right. So I'm just going to whip through these like David mentioned, just so we can get through to the three interesting cases we have. The other drug interaction, the next one I want to talk about, is Maraviroc, which confuses me all the time in terms of how much Maraviroc to use, because it's confusing, and I always have to look it up. So the reason is that it's a 3A4 and a PGP, which is a permeability glycoprotein substrate, and there are inhibitors and there are inducers. And the inhibitors are, for instance, the protease inhibitors. So if you're going to use a protease inhibitor, you're going to actually increase the levels of Maraviroc. Inducers decrease the levels, as we all know. So the major drug class that we think about is NNRTIs. So when we're co-administering other antiretrovirals, we need to be aware of this. So inducers decrease the levels, so we have to increase the dose of Maraviroc. However, if you're using a protease inhibitor and an NNRTI with Maraviroc, the inhibitors trump the inducers. So what I mean by this is that If you're using a protease inhibitor with an NRTI, you dose it like you were just using a protease inhibitor, meaning you decrease the dose. And here is a little table that kind of goes through the dosing. So for all protease inhibitors except tapranavir, which most people don't use anymore, you dose the maraviroc at a lower dose at 150 BID. If you're using an NNRTI-based regimen without a PI, except nevirapine and delaverdine, which most people are not on, again, you increase the dose to 600 milligrams BID. And as I mentioned, if you're on both, 150 milligrams BID. NRTIs, raltegravir, tapranavir, nevirapine, you don't need to do any kind of dose adjustment, so it's 300 milligrams BID. Number 3, etrovirine drug interaction. So it's an inducer and an inhibitor, as I put up there. There are some key ones, key drugs to avoid because of changes in drug levels with other anti-retrovirals. Tapranavir decreases the levels of etrovirine. Fosamprenavir, the interaction is that actually with etrovirine that there are increased levels of amprenavir and potential toxicity from that. With atazanavir, it actually decreases the levels of atazanavir, so not making that a safe combination to use. And in general, we don't use unboosted PIs, and that's recommended to avoid with etrovirine anyway. Or etravirine, I'm not quite sure how to say it. You can use it cautiously with lopinavir and darunavir. And I should have put a star next to the darunavir, the BID dosing. This was actually the 600 of darunavir BID with 100 of ritonavir. And this is what was used in the TRIO study that we are aware of that was for salvage patients on etrovirine and darunavir with raltegravir. And those patients, that dose was used and led to quite good outcomes in terms of virologic suppression. And so even though the Cmin is decreased by about 50%, it's felt to be safe to use together. Okay, so number 4 is antiepileptic drugs. We try to avoid phenytoin use in general when it comes to patients with seizure disorders who are HIV positive, just because of how it wreaks havoc with antiretrovirals. In terms of the PIs and the NNRTIs, it's best to just avoid them. You can use raltegravir and maraviroc at the dosing of 600 of BID. Carbamazepine we generally avoid with protease inhibitors, use with caution with NNRTIs. Again, the maraviroc dose is at the 600 BID. Lamotrigine we do use with caution with protease inhibitors. Lamotrigine in general we use with caution, again, because of the rash that can develop, and we generally titrate that up slowly. The anti-epileptic drug of choice for a lot of individuals with seizure disorder is usually I can't ever say that name. Keppra is the drug name, and gabapentin and pregabalin. So generally, our patients with seizure disorders go on Keppra as it has the minimal drug interactions with antiretrovirals. Lipid-lowering agents. This is another big class with our aging population of patients with HIV and a lot of comorbid cardiac disease. We use a lot of statin therapy, and it's important to know which ones to use and which ones not to use. The main thing to take away from this slide is that protease inhibitors inhibit statin metabolism, and the area under the curve for the statins can increase dramatically. As you can see with simvastatin, actually, and protease inhibitors, you can see an AUC increase of 500 to 3,000%. And obviously, when you're seeing that increased AUC, what we worry about is increased toxicity, and mainly myopathies, rhabdomyolysis is what we're concerned about. So the 3 preferred statins that we generally use are atorvastatin, rosuvastatin, and pravastatin. And again, you can see that we start with the lowest dose possible, really, just because even though these tend to have less of an interaction, the AUC is still increased with PI and atorvastatin 70 to 800%. So we start at 10 milligrams instead of 40 milligrams. Rosuvastatin, we start at 5 milligrams, and pravastatin, we start at 10 milligrams, and just titrate up slowly, monitoring for drug toxicity. Fluticasone and ritonavir is another one that some of you may not be aware of, and this is actually one of my patients who developed adrenal excess or cortisol excess due to this interaction. And basically what you see is increased systemic levels of fluticasone and cortisol excess, and you can see that this person had central fat deposition. You can consider replacing fluticasone with beclomethasone, and there were actually 2 posters at CROI this year that mentioned that beclomethasone really does not interact with ritonavir, and the levels do not increase. Antidepressants. Not that this, I just wanted to put this up there that there are interactions, but really what we do is titrate up the dose based on clinical response with SSRIs and bupropion. We don't necessarily make huge adjustments in the dosing based on that, except with tricyclics and trazodone, where we generally start at a lower dose when in conjunction with protease inhibitors, just because there is increased levels of those. And in RTIs, again, we just titrate based on clinical response. Erectile dysfunction drugs and protease inhibitors, basically what I tell my patients, you get more bang for your buck because you can use a quarter of a tablet instead of a full 100 milligram tablet and get the same effect, and that's what is the bottom line there. Number 9, TB medications. This is a big one, and something that's coming up in one of the cases is someone was interferon gamma release assay positive. So lots of interactions. Rifampin wreaks havoc with the CYP system there, and so the one that we generally use for patients, there are 2 options, and I think the main thing is efavirenz. There's a lot more data suggesting that 600 milligrams is probably sufficient. Some experts do recommend increasing the dose to 800 milligrams in conjunction with rifampin, though. Generally don't use with the other NNRTIs, traverine and nevirapine with rifampin. If you're on a PI-based regimen, rifampin decreases the PI levels considerably, so don't use those with rifampin. You can use rifabutin, but PIs increase the rifabutin levels, so you want to use QOD dosing or 150 milligram a day dosing. However, there have been cases of failure, clinical failure noted with PI use in rifabutin, and so the guidelines actually say consider checking rifabutin levels. And then if you're on raltegravir, increase the raltegravir to double dose if you're on rifampin. And the last one, salmeterol. This one is one that I brought up because not a lot of people know it, and it's in the package insert. And administration of a salmeterol with a PI is actually not recommended. And we have people with HIV actually have increased incidence of pulmonary disorders, emphysema, and we use a fair number of pulmonary medications. The reason is that there's an increased risk of toxicity with QTc prolongation, palpitations, and tachycardia, and there have been a number of case reports of this. So consider using formoterol instead if your patient is on a protease inhibitor. So lots and lots of interactions. I didn't even go through the OCPs, herbals, methadone, and azoles, but maybe we could save that for another talk. But again, here are the resources that I recommend looking at.